So welcome you all for Uromet 3.1 and we are conducting these sessions for the third time, and I can remember being the first presenter in the Uromet 1, little bit anxious, and now I have the privilege of moderating the session this time. As usual today the topic is renal cancer, and I think everyone is aware of the program where we have 4 presentations today and 15-minute presentation followed by discussion. And we have our expert panel today. I welcome Professor Neville sir and Anuruddha Abegunasekara sir and Dr. Wajira Mahesh, and we have Dr. Supundi Silva as our expert panel. I think without any delay, we can start the first presentation. Dr. Prasanna is going to present on core topics, including benign lesions of kidney. Dr. Prasanna, over to you.
Yes, sir. I want to share my presentation.
Yes.
Hello, sir.
Yes, we can hear. We can see your presentation. Yeah.
You can see my presentation, sir.
Yep.
Good evening, everyone. My teachers and the professors and colleagues. Today, the Uromet 3.1. We are starting with the renal cancer. My topic is 4 topics, including benign lesions. So, renal cancer is around 3% of all cancers and third in the urological cancers. Highest incidence noted in the Western countries. And male-female ratio is around 1.5 to 2:1 ratio. And renal masses usually we are categorized into malignant, benign, or infective or inflammatory in origin. Malignant renal tumors can be categorized into renal cell cancers, urothelial-based malignancies, sarcomas, embryonic or pediatric tumors, lymphomas, and metastatic to the kidney. Renal cell cancers, most of the renal masses, around 90%, are renal cell in origin. Those are originate from the tubuloepithelial cell. So basically, it's a adeno type of carcinoma, but usually we don't call as adenocarcinoma, and originating from tubuloepithelial cells. So it consists of clear cell renal tumors, papillary renal tumors, oncocytic and chromophobe renal tumors, collecting duct tumors, and there are other subtypes like clear cell papillary renal cell tumors, and most accurately molecularly defined renal tumors like TFE3 rearranged or TFEB altered renal tumors. So when we look at the evaluation of the renal cell tumor classification from 1980s to 2022, now so WHO categorization, it's stepwise there are changes, and recent 2022 WHO classification system, there are some changes with they included mainly the molecularly defined tumors, and other main variations they have removed this. Previously we studied the papillary type 1 and type 2, but now they are categorized as a papillary renal cell tumors. The type 1 is mainly called as a classic category. So when we look at the pathological classification, again it can be malignant or benign. So in the malignant renal cell carcinoma, again we have clear cell RCC, papillary, chromoform. There are other variants. And urothelium-based cancers, mainly urothelial carcinoma, and sarcoma, mainly leiomyosarcoma, liposarcoma, and nephroblastic tumors, mainly in the pediatric, like a Wilms tumor, and carcinoma associated with the nephroblastoma, mainly the neuroendocrine tumors, and the metastasis and invasion by the adjacent neoplasm. So those are malignant categories. And benign, again, we can divide into cystic lesion or solid lesion. Cystic lesions are the mainly simple cyst and hemorrhagic cyst. And solid lesion, mainly we are looking at the angiomyolipoma, oncocytoma, papillary adenoma. Those are the main benign lesions. And there are vascular lesions, pseudotumor, and inflammatory or infective mass. So when we look at the clinical presentation, most of the time it's asymptomatic. So around 50 to 60% time asymptomatic, and there are classic pride of symptoms. It includes flank pain, hematuria, and loin mass, but it's usually less than 10%. And features of paraneoplastic symptoms, they can present around 30% of the time. They can present with the paraneoplastic symptoms and symptoms due to metastasis. And when we look at the physical examination, mainly we can examine palpable abdominal mass, cervical lymphadenopathy, and non-reducing varicocele and bilateral angular edema. They may show the IVC involvement. And when we look at the risk factors, main risk factors is the smoking, then obesity and the hypertension with the metabolic syndrome, end-stage renal disease, and those who are undergoing the chronic hemodialysis. And there are hereditary conditions, mainly VHL disease. It's a autosomal dominant disease involving the chromosome 3, and hereditary papillary renal cell carcinoma type 1, hereditary leiomyomatosis, Burke-Dubé syndrome, and P10-Howden syndrome, and tuberous sclerosis complex. So usually the renal cancers are sporadic, more than 90% of the time sporadic, but around 5 to 8% of the time it is hereditary in nature. So when we suspect the hereditary cancers are when the family history of the hereditary cancer syndromes are there, or patient with more than one synchronous or metagonous RCC, or RCC patient with the family history of RCC, or patients with RCC, the personal or family history of at least one extrarenal manifestation associated with the hereditary cancer. That means if the usually VHL associated with the paragangliomas or pancreatic or liver cyst or retinoblastomas or others are cerebral hemangiomas, or if they're present with the extrarenal manifestation, then we have to suspect the HRCC. And early onset RCC, mainly the younger than 45 years old, and any patient with even single hemangioblastoma of the central nervous system or the retinal or rhabdomyoid malignant tumors, then we have to suspect the hereditary cancer syndromes. When we look at the diagnosis, so even though kidney cancer is a radiologist disease, so we are mainly dependent on the radiologist. So most of the renal cancers we are diagnosed by the imaging, mainly the three-phase CT IVU. So important criteria to diagnose the contrast CT is the enhancement. Mainly we are looking for the enhancement. We are comparatively with the non-contrast CT scan, we are looking for the enhancement of the contrast. If it is more than 15 to 20 count-fill units, it's a diagnosis for the renal cell cancer. Other than the contrast CT, we can use the contrast enhanced MRI and the contrast enhanced ultrasound studies. So MRI usually we use the T2 weighted images, but there are diffusion images are there. And MRI usually we are indicated for the patients who are allergic to contrast agents, CT contrast agents, or during the pregnancy. And the MRI gives more detail regarding the extent of the IVC thrombus and whether this IVC thrombus is infiltration into the IVC wall, then we can get the more anatomical delineation. And the MRI is more sensitive for the small renal masses. The masses less than 2 centimeter size, it is more sensitive. And when we look at the contrast enhanced ultrasound, having comparatively good sensitivity to characterize the renal masses. So it is mainly useful for the follow-up to avoid the excessive radiation. So these are the image of the mainly three-phase CT. So and the MRI. Usually CT we are taking the four images, non-contrast, and the arterial phase, venous phase, and the expiratory phase. So arterial phase usually in the 30-second and venous phase in the 70-second, and expiratory phase in 15 minutes time. When we look at the cystic renal masses, so defined as mass containing less than 25% of the enhancing or solid component, we are categorized as cystic renal masses. To classify the cystic renal masses, there are different classifications. Mainly, CT-based classification is the Bosniak classification system. So it consists of 5 classes: class 1, 2, 2F, 3, and 4. So it mainly looking for the wall size, whether it is thin wall or thick wall, mainly the less than 2 millimeter size or more than 2 millimeter size. Then the Stiani septate, Stiani solid component, and the calcification. So these are the factors they are looking for. And usually Bosniak type 1 and type 2 are no need any follow-up. And these Bosniak 2F, 3, and 4, they are having the malignant chances during the follow-up period. Usually 2F having the around 5 to 10%, and Bosniak 3 around 50%, and Bosniak 4 around 85% chance of malignancy in the follow-up. So Bosniak 2F usually we are managing with the follow-up with the imaging, and 3 and 4 usually we are managing with the surgical management. So this is the imaging summary. So when we suspect the renal mass, so we have to first in the ultrasound, we have to think whether it's a complex cyst or solid mass, or either it's a simple cyst. If it is simple cyst, then we can discharge the patient. No need any follow-up. And if it is complex cyst or solid masses, then we have to think about the whether patient is having contrast allergy or not. If contrast allergy, then we can do the MRI with or without gadolinium. Only issue with the gadolinium is the patient can develop again anaphylactic or the nephrogenic systemic fibrosis. Then if there's no significant contrast allergy, then we have to think about the patient is having what's the GFR, EGFR. If the EGFR is good, then we can go ahead with the contrast CT or the contrast MRI. But if EGFR is between the 30 to 45, then we can give the or during procedure hydration to avoid the contrast inducing nephropathy. But if it is EGFR less than 30, then we have to think about the non-contrast CT or non-contrast MRI. And renal mass biopsy. So usually it's a radiological diagnosis, but there are some indications like radiologically indeterminate lesions or small renal masses. Then we have to think about the renal biopsy, because small renal masses around 20% of time benign. When you look at the less than 1 centimeter small masses, small renal mass, around 46% are benign. So to avoid this unnecessarily over treatment, we have to think about the renal mass biopsy. Other indications are if the origin of the mass is like if you are suspecting like hematologic or metastatic origin, then we can go ahead with the biopsy and evaluation of the metastatic renal disease before you are going to go the definitive treatment or targeted therapies. Then when we look at the accuracy and diagnostic outcome, so renal biopsy is around sensitivity, specificity, and positive predictive values are around more than 95%. But main concern is the low negative predictive value. It's around 63%. That means around 37% of the negative renal biopsies sometimes harbor the malignancies. So it means there's a low negative predictive value. And when we look at the safety of the renal biopsy procedure, the complication rate is very minimal, 1.4 to 4.7%, and major complications is less than 0.5%. So mainly the hematoma, macroscopic hematuria, and clinically significant pain. And hemorrhage requiring transfusion is around 0.7%. And when we look at the staging and classification systems, so validated staging system nowadays is the tumor node metastasis staging system, the 8th edition. And there are classification system for the mainly the anatomical purposes. These are the Padua system or renal nephrometry score, C index, or ABC scoring system. These are the for the anatomical purposes. So when we look at the TNM classification, there are T1 to T4 for the tumor size and the regional lymph node 7 centimeter. Again, there are subcategory T1A and T1B. And T2, again, there are two subcategories. It mainly the 7 to 10 centimeter size, more than 7 centimeter size. And T3 consists of ABC categories. So mainly at T3A, there are four things are there. Main is the renal vein involvement, calcium system involvement, perinephric fat, and sinus fat. And T3B, mainly the IVC involvement below the diaphragm, and C is the above the diaphragm IVC involvement. And humanoid beyond the Geroda fascia, mainly with the adrenal gland, is the consists as T4 disease. And when we look at the prognostic factors, it can be classified into anatomical, histological, and clinical and molecular factors. So anatomical factors mainly included in the TNM, like a tumor size, mode, and metastasis. And histological factors mainly the tumor grade. Tumor grade previously we used the Birmingham Perman classification tumor grading system, but nowadays we are using WHO ISUP grading system. Mainly prominence of nucleoli. We are looking for prominence of nucleoli and subtypes of histology, like whether it is papillary, clear cells, or chromophore, and lymphovascular invasion, tumor necrosis, sarcomatoid or rhabdomyoid changes, and invasion in collecting system. And clinical factors mainly patient's performance status, local symptoms, cancer cachexia, anemia, platelet count, neutrophil count, lymphocyte count. We can use the neutrophil lymphocyte ratio, CRP. These are the clinical factors. And molecular factors, there are molecular markers are there, mainly carbonic anhydrase 9, vascular endothelial growth factor, these proliferation factors like Ki67, P53, those are the molecular factors. With these factors, there are validated prognostic models are there. They are categorized into certain histological, like Ibovich for the mainly clear cell cancer and the Venus for the papillary. And for the metastatic, there are models are there for the prognostic assessment. And when we look at the benign renal masses, oncocytoma, first one is the oncocytoma. It's the most common benign lesions enhancing benign mass. Up to 25% of the renal mass, the small renal masses represent them. Usually unilateral, but around 5% of the time bilateral in nature. Rosy mahogany brown surface with the central scar. So with the central scar, usually we can diagnose in the CT scan. Histologically has overlapping features with the chromophore RCC or papillary RCC, can present with perirenal fat invasion and renal vein invasion, but it won't carry a poor prognosis like our renal cell cancer. Definitive diagnosis, post-operative histological is the definitive diagnosis. Hypervascularity and central scar suggest diagnosis, but insufficient for the definitive diagnosis. So in the CT scan, like enhancing with the central scar, we can suggest for the oncocytoma. Main management is the post-surgical observation, but if diagnosis made with biopsy active surveillance, we can make the active surveillance. as place for biopsy if suspect preoperative. And when we look at the other one, the angiomyolipomas, composed of dysmorphic, it is composed of dysmorphic blood cells, smooth muscles, and adipose tissue. It mainly female predominance. Peak age is 4 to 5 decades. Tuberous sclerosis complex is the most well-described hereditary cause for angiomyolipoma. For patients with the tuberous sclerosis, they develop the multiple angiomyolipoma with bilateral nature, mostly diagnosed incidentally with the imaging as presence of macroscopic fat on CT or MRI. So when we look at this fat-containing masses, these council unit are between the minus 15 to 20 council unit. So we can diagnose. But if it is fat for angiomyolipoma, then we can confuse with our renal cell cancers. So fat for angiomyolipoma, fat-containing RCC, liposarcoma, oncocytoma, they are more difficult to diagnose with the our routine contrasting and CT. Most common cause for spontaneous retroperitoneal hemorrhage. It kept around the name, classical name is the Wunderlich syndrome. It's around 15%. That's mean spontaneous retroperitoneal hemorrhage. It consists of flank pain, flank mass, and the hypovolemic shock. So management of angiomyolipoma depends on whether it is sporadic or syndromic, like tuberous sclerosis, and presence of symptoms and risk of hemorrhage.
And it's time for questions. And our expert panel is here for any queries.
Okay, can I ask a question from the presenter? Short
Yes.
question.
Yes, sir.
One thing is, what is the place of biopsy in cystic masses?
Sorry, sir, what is that?
Whether he has mentioned it. What is the place of biopsy in cystic lesions? Cystic masses. Let us say it is.
If it is, if it is a solid component is there, then we can hold it with the biopsy, sir. But usually we don't do because of there's a low sensitivity of biopsy in the cystic masses. To avoid the low sensitivity, we can combine with the biopsy and the FNA. We can combine both together. Then we can increase the sensitivity of cystic renal masses.
What is the current EUA recommendation for biopsy and 3, 4, 5, and 4 and 5, 3 and 4? Current European guidelines?
Yes, sir.
What it says is not to do it. Okay, biopsy is not indicated at all. So cystic masses, if you are in doubt, you excise it laparoscopically open. You excise it if you are in doubt, but the sensitivity is so low that cystic masses is generally even 2F. It's not advisable to do a biopsy. That's a strong recommendation. Okay. What is the in a small renal mass? What is the place of fine needle aspiration? Is there a place for fine needle aspiration or not? Because the radiologist might suggest that I will do a fine needle aspiration because it's scared to do a co-biopsy. So what will be your advice?
Fine needle aspiration, the sensitivity is very low, sir. So it is not advisable for the fine needle purpose of differentiating the small renal masses.
Yes, there's no place at all. Okay, so you have to put your hood down and say that, there is no place. Either do a co-biopsy or then otherwise I have to go ahead and excise it and send for histology. Right? Okay. Right. I think any other questions from the rest of the panel or other participants? Okay, in the absence, anybody else to question? Yeah, those are the questions I thought of asking. Should we move on to the next session? Or? So one more thing then shall I ask while we are silent? Can you hear me, everybody? Yeah, okay. If you can hear me, Prasanna, this when you ask for a CT, contrast in a CT of especially a small renal mass, how would you specifically, what details would you really ask for? Apart from the diagnosis, what other? Yeah.
CT IV with renal angiogram.
Yes, yes. Some details about the
arterial anatomy.
Sorry. Hello.
Hello, sir.
Are we connected?
Yeah.
Why is it necessary to ask for the specifically for the angiographic phase?
Mainly, when we think about the nephron sparing surgery or laparoscopically, when we do the nephron sparing surgery.
Yeah, that's right. It's going to be useful, isn't it?
Yes.
Any other thing anybody else would like to ask? How?
Hello.
Yeah. So.
Yes, I was
yeah.
asking about the incidence and prevalence of renal cancer in Sri Lanka, sir.
I won't know offhand. I think Anuruddha will be the best for epidemiological information. I don't know whether we have done a countrywide study to give a proper answer. I think this is for the future generations to collect all the information. Is Anuruddha with us or not? Is Dr. Gunasekar is there? That's or not?
Seems
he said he can't take part because he's having a viral fever, no?
Oh,
yeah. He said he's down with flu, and Professor will preside. He has sent a message.
Okay, right. Right. I think I don't think we have a proper answer for that. So I think in the future, I think we should have a cancer registry. Unless Manjulo or some other senior colleagues know about an exact figure. I think it is for the future for us to collect all the information, because we have a big problem because some of them straight away go to Maharagama, and I think from all the units we have to collect the data and then get a figure.
So I would like to thank Dr. Prasanna, and then we can move on to the next presentation with Dinendra Madhusankar, who is prepared with small renal mass. Dinendra, over to you.
Yeah, good day to all. I'm going to discuss about the management of a small renal mass. First of all, what is small renal mass? It is defined as enhancing lesion, which is occurred in the kidney, and the size is they take as less than 4 centimeter. And this small renal mass majority, nowadays, the incidence is more because of the advent of the imaging modalities, and 80% of them are malignant and 20 to 30% of them are benign. And the small renal masses, they can be either benign or malignant lesion, as mentioned. The benign lesions can be either lipid-poor angiomyolipomas, oncocytomas, and malignant lesions, as previous speaker said, can be renal lesions, lymphoma or metastatic from nether malignancy, or sarcomas. And in the evaluation of a small renal mass, CT urogram plays major role, and the presence of enhancement, pre and post contrast enhancement of 15 Hounsfield unit is significant. And for the more accuracy, we can use MR urogram. And if the lesion is more of cystic origin lesion, and there's a place for contrast enhanced ultrasound scan, which will increase both sensitivity and specificity. And is there a place for renal biopsy in the evaluation of small renal mass? Renal biopsy can increase the sensitivity and specificity, namely 70% and 94%, and with a good positive predictive value in the diagnosis of small renal mass. And the indications for renal biopsy are they when the lesion is radiologically indeterminate, or if you are going to ablate the lesion and before ablation to confirm the diagnosis, and in the patients who are candidate for active surveillance. And not relevant to this, if the patient is having metastatic disease before starting on systemic treatment to get the diagnosis of the lesion. And the contraindications of renal lesions are if the patient is comorbid and very frail, and if you are planning for watchful waiting, there's no place of renal biopsy. And imaging diagnosed patients whom awaiting surgery, there's no place of renal biopsy. And as Neville said, there's no place of biopsy in cystic lesions without obvious solid component. And discussing about this biopsy technique, the coaxial technique is described because it will reduce the risk of tumor seeding. And it is done under local anesthesia, either using 16 to 18 gauge core needle. And it can be performed either ultrasound or CT guidance. And EU recommends that 2 cores of samples are adequate for the procedure, and we should avoid necrotic center areas when taking the biopsy. And side effect profile also less. It can be hematoma, perinephric hematuria, and pain and sometimes pneumothorax has been reported. But overall side effect profile is less. Then after evaluating the small renal mass, in the management, there are 4 main steps of treatment. We can embark on surgical treatment, ablative treatment, active surveillance, or watchful waiting. In the surgical management, it has been the historical benchmark of the treatment, and for a small renal mass, the treatment of choice would be partial nephrectomy. And when we compare with partial nephrectomy versus radical nephrectomy, the overall survival of partial nephrectomy equals to radical nephrectomy. And it is more beneficial for the patients in view of renal preservation, as well as it will reduce the cardiovascular related deaths. And this partial nephrectomy is more beneficial in young patient groups rather than elderly. And it is treatment of choice for patients, especially who are having already renal impairment, or patients with single function kidney, or with patients with syndromic like von Hippel-Lindau disease. Patient might have concurrent other lesions. So in that group, partial nephrectomy plays major role. And when compared with radical nephrectomy, although it is oncologically similar, but surgical wise, complication profile is much more higher rather than radical nephrectomy. It can be perioperative bleeding or reactional bleeding, or urinoma, and more positive tumor resection margin can be there when compared to radical nephrectomy. And surgical technique can be either open technique, laparoscopic, or robotic. When compared these 3 techniques, there's no overall survival difference between each techniques. But there are certain pros and cons during the techniques. For example, in laparoscopic partial nephrectomy, the patient might have less bleeding, less pain, and less hospital stay and early return to work. Thereby, same time, he will have the disadvantage of increased warm ischemia time and increased operative time. Thereby, renal impairment can be more than the open technique. And robotic partial nephrectomy is superior in compared with laparoscopic partial nephrectomy because it score, Padua score, C index, ABC score, and score, as my previous speaker mentioned, as there are certain characters we can see in the lesion, and namely the radius, the exophytic or endophytic properties of the lesion, and nearness to the renal pelvis, and whether the anterior or posterior, and the location in relative to the polar lines. And comparing these factors, they give the number, and number is 12. If it is more than 8, it means the patient need radical nephrectomy. But majority small renal masses are well below the that value, so they will benefit with partial nephrectomy. And after partial nephrectomy, what if the resection margins are, what about the resection margin? The EUA recommends 1 millimeter margin is accepted. And to increase the marginal clearance during surgery, we can use intraoperative ultrasound assessment, or this newer technique like Firefly technique with contrast dye injection, and same time tumor-based diathermy. So that will reduce the marginal recurrence. And if is there a place for enucleation? Sometimes when the malignant risk is less, and in patients with multiple tumors like von Hippel-Lindau disease, there's a place for enucleation, but the risk is the recurrences are more when compared with adequate resection. And what if the margin is positive following partial nephrectomy? If the margin is positive, there can be high risk of recurrences, and it increases more than 5-fold. But overall wise, there's no risk of increase of metastasis or cancer-specific survival. So the options for these positive margins, we can either intense follow up the patients or embark on other ablative treatment. And if we do the re-resection or the radical nephrectomy, sometimes it might be an over-treatment, but depending on the patient's histology and the tumor-specific factors, we can decide these treatments also. And apart from surgical techniques, the other important aspect is the ablative techniques, which is a good treatment modality for small renal masses. With the current technologies, these ablative techniques are much more occur in nowadays, and there are certain techniques like cryoablation, radiofrequency ablation, or microwave ablations are there. And some recent meta-analysis shows that the overall survival similar when compared with these surgical techniques, but some researchers, some evidences show that still surgical technique is the best. And the recurrence-free survival is less in ablative techniques when compared with partial nephrectomy. And the patient perioperative morbidity-wise, these ablative techniques are much better, and there is less complications. And out of those complications, bleeding is the commonest complication. But overall complication profile is less. And for patients who are not fit for surgery, and failure of active surveillance, and these tumors with genetic predisposition, and patients with impaired renal function or solitary kidney, those patients are better treated with ablative techniques. And there are certain contraindications. If the lesion is in a hilar tumor, or the tumor is very close to the ureter, a patient with active illness or an infection, they advise not to embark on ablative techniques. And percutaneous renal biopsy is recommended before ablation, recommended by EUA. And same time, preoperative imaging is mandatory to assess the lesion and the adjacent structures. And there is no specific scope to decide on the treatment, but there is this modified renal nephrometry score can be used as a guide for the ablative techniques. Options would be cryoablation, which is a cold ablation, radiofrequency thermal ablation, and microwave ablations. The approaches can be either subcutaneous approach or the laparoscopic approach. Briefing about this ablative techniques, the cryoablation, which is much more superior than the radiofrequency ablation in view of metastatic free survival. It is a cold-based technique where the patient is punched with multiple needles, and it is connected to a liquid gas like argon, and they generate this low temperature like minus 190 Celsius. So this low temperature will cause tumor ablation by two different mechanisms. This cell death occurs in freezing cycle where the direct cytotoxic injury due to this ice crystallization within the cells, and it will lead to cell damage. And in the thawing cycle, there's delayed microcirculatory failure, which resulted in tissue ischemia. So thereby it is much more effective, and we can use real-time monitoring to see the ablation of the lesion. We can notice that there's this ice ball formation and ablation within the lesion. And they advise to do extra 1 centimeter margin of ablation to get the complete tumor ablation control. In the radiofrequency ablation technique, there are also same subcutaneous probes are inserted to the lesion under CT guidance, and this radiofrequency energy is inserted through these probes, and they will generate heat. When compared with the cryoablation, here they generate heat of 100 Celsius for a shorter period, and it will lead into cell death, tissue vaporization, and eschar formation. And there are a lot of evidences are there in comparing these two techniques, and they assess this overall survival, cancer-specific survival, and recurrence-free survival, and disease-free survival. And different studies shows different numbers, but overall wise, the numbers are in more favor of good outcome. And comparing these two techniques, cryoablation is superior in view of oncological control of the lesion. And what about renal function outcome following this surgical or ablative techniques? Most of the patient will go into shorter duration renal worsening. They say about 1 to 40. 40 of EGFR reduction can be seen following whatever this treatment. But then with the time that will improve, and after about 1 to 6 months time, they will improve and the renal function will be stabilized. But if we embark on ablative treatment, this renal function recovery is much more superior rather than surgical procedure, because there's no ischemia or no clamping. And this is benefit for patients who are already CKD or solitary kidney patients. And how do we assess the success of ablation, and how do we follow up these patients? This initial post-ablation study is essential to see the success of ablation. There we can see a remnant ablative tissue, but there's no enhancement. So thereby we can confirm that ablation is success. And this EUA recommend that initial scan at 6 months followed by annual CT for 5 years. After 5 years, CT or MRI once in 2 years we can do for assess the patients. And during this follow-up period, how we identify the recurrence? When we do the imaging, if there's visually enlarging neoplasm or new nodularity seen in the previous surgical area, or if the enhancement is failed to regress, that means the patient is having a recurrence. Then after ablative treatment, the other modality is active surveillance. Not all small renal masses are having same malignant potential, and not all the patients need same treatment. So some lesions do not warrant a surgery at all. So active surveillance is another option, especially patients who are elderly and not fit for surgical treatments, main surgical treatments. And these patients can be followed with serial imaging to assess the growth of the lesions. And once this active surveillance is failed, then they can offer curative treatment. So it is different from watchful waiting, because here we are planning for curative intention. And the follow-up protocol is patient can be initial follow-up with 3 months initially, and then 6 months, then 6 monthly for 3 years, then yearly. So initial close follow-up is needed to assess the lesion. In this follow-up, we assess the lesion growth. Usually if the growth is more than 5 millimeter per year, or if the lesion is double less than 12 months period, or if the lesion size cutoff exceeds more than 4 centimeter, then active surveillance is failing and patient need the definitive treatment. Either we have to rebiopsy the lesion, or else we have to embark on the curative treatment, either ablation or partial nephrectomy. Then there are some patients who present with small renal mass and who are already surgically unfit, elderly with short life expectancy. In that category, we are not going to offer curative interventions. We just watchful wait for those patients without no need of image follow-up or any biopsy protocol here. It's just symptomatic control. So in the management of this small renal mass, this Princess Margaret's Cancer Center has developed a protocol which is described in the BJUI. There they describe all these lesions patients undergo multidisciplinary team approach by the involvement of expert interventional radiologist and uropathologist to define the biopsy, the adequacy and the correct diagnosis, and the uro-oncologist and the urological surgeon. So in this team, they can assess the lesion properly and come to a pre-op diagnosis and the treatment protocol. And in deciding the treatment, they use these radiological characteristics, the location, size, morphology, and the growth rate of the lesion, as well as patient factors, patient's age, comorbids, preoperative renal function, are assessed and individualized treatment protocol they have devised. So this like protocol where patient present with small renal mass and undergo MDT, if the lesion is less than 1 centimeter, then there's no need of treatment according to the tumor behavior, because less than 1 centimeter is very unlikely to cause tumor metastasis or tumor problem. So they will follow up these patients until the lesion exceeds 1 centimeter. And they are not going to biopsy even if it is less than 1. And same time, after MDT, if the patient is not fit for any surgical or ablative treatment, patients are diverted to watchful waiting. And after the careful assessment, they plan for renal biopsy of these lesions, as some can be benign lesions. So if the renal biopsy comes as non-diagnostic, it doesn't exclude the malignant potential. So they are advised to go for rebiopsy to increase the sensitivity and the diagnosis. And after renal biopsy, then they divide the patients into either benign or malignant lesions. Benign lesions, those patients can undergo active surveillance with the previously explained protocol. And if it is malignant lesions, then again, depending on radiological factors as well as patient factors, they come into a conclusion whether they are suitable for surgical treatment, ablative treatment, or the active surveillance. That is the protocol they have planned for the management of a small renal mass. And that's I want to discuss here, sir. So the references are UA, AU, and the BJUI reviews. So thank you very much.
Okay, so it's time for discussion and questions.
Okay. But can you elaborate on the word indeterminate masses in a report of radiology report of a small renal mass? What do you mean by indeterminate mass?
So in the CT, the enhancement is the main factor they are going to assess to decide on the lesion. So if it is more than 15 contrast enhancement differences there, then it is more favor of a malignant lesion. But if the lesion comes less than that, but not purely benign, like 10 to 15 lesions, and in such cases, they want another imaging modality or biopsy to decide the treatments.
When it comes to MRI and CTU, do you think there is an advantage of doing MRI over CTU in all cases?
No, sir. CT urogram is good for diagnosis of small renal mass, especially in resource poor setting. And if it is inconclusive, then we can embark MRI. Otherwise, CT is beneficial as a first-line imaging, sir.
There's no added advantage of doing MRI.
Yes.
As a first-line investigation, isn't it?
Yes.
So what will be the indications for MRI? Straight away go for an MRI.
If the patient is not fit for CTs, then contrast allergy, or if there's a renal impairment, then we can go for MRI. And other contraindications like pregnancy, then there's space for MRI. Sir.
Right. Okay. And this partial nephrectomy, you mentioned about partial nephrectomy versus a nephrectomy. What evidence do you have to show that partial nephrectomy is much better than radical nephrectomy when it comes to small renal masses?
This EORTC has shows that there are evidences in view of overall oncological survival, both is equals. There's no added advantage. But when compared with the side effect profile, partial nephrectomy is has more side effect profile rather than radical nephrectomy in view of bleeding, urinoma, and other local complications, positive surgical margin.
Yeah.
And
So
overall,
why partial nephrectomy then?
partial
So if it is
nephrectomy has the added
disadvantageous,
advantage.
why should we do partial nephrectomy?
Yeah, partial nephrectomy has the added advantages of nephron sparing. So, post-operative renal impairment is less if the patient is having already impaired kidney. But if it is more than 60 eGFR, there's no added benefit of partial versus radicals. But same
Yes.
time, they have showed that cardiovascular risk also minimized if the patient is undergone partial nephrectomy, if the patient is young, especially. But in elderly, there's no much of difference.
Right. Yes, EGFR plays a role, I think, when it comes to it, isn't it? So if
Yes.
this EGFR is low, then of course partial nephrectomy in the long run is much more beneficial. Okay. And you said something about enucleation. Is there any evidence to show that enucleation is worse than a partial nephrectomy? Is there higher recurrence rates or higher positive margins in enucleation compared to partial nephrectomy?
Say, I can't quote evidences, sir, but in the review article, they said that enucleation always carries recurrence risk compared with partial nephrectomy, sir, because there the margin is margin clearance is less.
Okay. So what is there any way of reducing these margins, positive margins, or recurrence rates in enucleation? Because in a endophytic tumor, enucleation or multiple tumors, enucleation becomes a useful method of treating it. So,
Yes.
is there any way of reducing it? There is a study
Yes.
sometimes done but in 15 years ago, Japanese study comparing enucleation to partial nephrectomy. And it's not actually enucleation to partial nephrectomy, enucleation with tumor-based diathermy of the tumor base compared to enucleation alone. They have found that there's no difference. So enucleation alone is also as good as, diathermizing it. So I think, but anyway, using your common sense, I think diathermizing the base, if you are doing an enucleation, will destroy any tumor left there. But this concept of pseudopodia going through the tumor capsule, that is now historical. Okay, I don't know whether you have heard about it even. Pathology, if you go through RCC pathology, there is a pseudocapsule and then little processes are going outside there. That's why enucleation was abandoned. But I think that is not, in practice, it is not. So don't hesitate to, my feeling is that don't hesitate to enucleate. The indication is there. And can I ask you now, you are the expert here on partial nephrectomy and small renal masses in this podium. What sort of approach you will do if you are doing a partial nephrectomy? What approaches, the surgical approach you will prefer? So, as you know, it's open surgical or laparoscopy or robotics. So, what will you prefer? What is guideline says?
So, guideline says the oncological outcome is similar in any procedures. Open, laparoscopic, or radical, oncological outcome is similar.
That's
but
true.
Patient mobility and the post-operative management-wise, laparoscopic and robotic is superior versus open surgeries. And same time, the warm ischemia time can be minimized if we embark on robotic. But in laparoscopic technique, the renal impairment due to warm ischemia is much more.
So the evidence is strong or weak in advising to go ahead with open versus laparoscopic?
Mm.
There's strong evidence to show that you must go for. Like now in radical nephrectomy, there's very strong evidence. Evidence level is strong
Yes.
to do laparoscopic nephrectomy. So
Yes.
that means, you have to go for it.
Yes.
But in partial nephrectomy, does the same thing applies?
I think no, sir, because there are still
Yeah.
benefits of open when compared with laparoscopy, sir.
Yes, till the guidelines, the strength of the evidence is weak when you are comparing partial nephrectomy. Open nephrectomy is strong.
Yes.
Okay, so if we are doing it, not laparoscopic sort of expert, what approach will you, what is the approach you prefer to do a partial nephrectomy? What I mean is intraperitoneal or retroperitoneal?
Retroperitoneal approach can be performed, sir, without violating the abdominal planes. And if we can get control of the renal pedicle, that is our initial goal. And same time, to prevent this ischemia time, we can do intraoperative cooling of the kidney. And same time, resect and get the good control to prevent postoperative bleeding of the tumor beds.
Okay, final, one practical question. So when you decide to do retroperitoneal approach against transperitoneal approach or the vice versa, are there any factors you will think of the patient? This is a practical question. Or you will do partial nephrectomy in all retroperitoneal approach?
As much as possible, retroperitoneal approach would be preferred, sir. But if the vascular control is a problem, then transperitoneal approach would be better.
What do you mean by vascular control?
If like in right side, if there's a risk of bleeding and the vascular hilum is much more difficult to get the retroperitoneal, then open approach would be better. Otherwise, majority of the cases can be done with the retroperitoneal approach, sir.
The site matters and the location of the tumor. Location of the tumor.
Yes.
So if it is close to the pedicle, I think the transperitoneal approach will be much better. On the right side also,
Yes.
transperitoneal, and also the body morphus, the size of the patient. I mean,
yes,
you
sir.
have a 35 BMI patient, and there's a big handle there on the bucket. Handles are on the sides. Retroperitoneal approach will be a bit of a difficult thing. So consider those things.
Right.
And I think we are passing the time. Any other questions? Because I should not
There
be.
are a couple of questions
Yeah, please,
posted.
please.
One is, what are the indications of biopsy in Bosniak 2F/3 lesion? So I think it's already answered that cystic lesions are not to be biopsied. And there's other question, still can we consider ablation who is having strong family suggestive of von Hippel-Lindau?
Sorry, what was the question? Sorry.
Can we consider ablation who is having strong family history suggestive of von Hippel-Lindau? I think if von Hippel-Lindau patient having a small renal mass.
The speaker can probably answer that.
Yeah.
Yes, sir. In that scenario, sir, the ablation treatment would be better because patient might have another lesions in coming years. So to preserve renal function, if it is a small renal mass, ablation would be better. But it should be always multidisciplinary team decisions with the patient and the relevant urologist and the oncologist.
And next question, is there a difference between active surveillance and watchful waiting? I think Madhushan can summarize.
Yes, there's two different entities in the management. Active surveillance is it's a curative intention treatment modality where initially we observe that small renal mass progression, whether it's benign appearance or malignant. Then depending on its progression, we embark on treatment. Watchful waiting, where the patient is not fit for surgical treatment or other ablative treatments, there we just follow up the patients only to comfort their symptoms. There's no intention of curative intention.
Okay, so I think we can move on
Let
to
me ask the final
Yes, sir.
question. 1 minute. zero ischemia. What is your idea about zero ischemia partial nephrectomy? What are the recommendations on zero ischemia partial nephrectomy? Where you do off clamping, that is without clamps, doing partial nephrectomy.
Uh,
Is it advisable or not? Because there is a concept called zero ischemia off clamp partial nephrectomy. So what is your opinion about it? And what does the guideline say?
So I'm not clearly heard about it, but in the management, I think it reduced the ischemia. So there's a postoperative renal impairment is less, but there the bleeding risk is intraoperative bleeding and the perioperative bleeding risk is more. But if we can get good hemostasis, it is much more better than doing clamping, sir.
Yes, the evidence to show that is interval Gill from States, I think, try to popularize it, but the guidelines all say that the zero ischemia doesn't have any advantage. I mean, the comparative studies have shown that there is no advantage, so that concept is not widely accepted because there is no added advantage of doing the enucleation or the resection without this. Just know that it has not come to the guidelines. Okay.
Right.
Yes.
Right.
Thank you, sir.
Any other questions?
Dinendra, Supun here. Hello.
Hello.
We are with you.
Yes.
Hi, sir. Dinendra, now what kind of post-operative problems or complications would you anticipate if you refer a patient to ablative treatments for a small renal mass? Now, we all understand that it is done by a different group of, it's mainly done by radiologists. So if you refer a patient to an ablation, what kind of post-operative problems that you will anticipate? Because those comes to you. The radiologist will ablate and you will have to look after the patient afterwards.
Yes. In the immediate perioperative period, there can be pain, there can be perinephric hematoma, and if it is damaging the pelvic system, hematuria, clot colic, and clot retentions. And if the lesion is more closer to the vascular pedicle, vascular injury risk is there, sir. And same time, depending on the site, adjacent structure injury. And in post later follow-up, the problems is the tumor recurrence and inadequate ablation of the lesion.
Excellent answer. I mean, if you now go back and see your criteria for partial nephrectomy, I mean, the criteria, patient selection criteria for ablation and partial nephrectomy, you won't see much of a difference.
Yes.
So,
but,
yeah.
Yeah, but they have for the deciding factor, they have modified. They have decided a modified nephrometry score to guide the ablation possibilities.
Exactly. So exactly the point. It's not much different from the renal nephrometry score, isn't it? Very little differences, you know. So
yes.
The point I'm trying to make here is that there's no real difference in selecting patients for partial nephrectomy compared to ablative techniques. Are you with me?
Yes. Yes.
So I mean, it's again, even it again depends on the protocol of the country or the area that you are working in. If the radiologist wants to do more, they get more ablations. If the urologists are so powerful and they can do all the robotic upper tract operations, you can still offer partial nephrectomy. So there is no real difference in selecting patients for ablation or partial nephrectomy.
Yes.
It again depends on the infrastructure you have. Again, the Princess Margaret protocol is only applicable for that hospital. Different hospitals have different protocols, and it all depends on the facilities you have. So partial nephrectomy and ablation are pretty much, the two sides of a coin, I would say.
Yes.
Thank you.
Yes. Thank you.
Okay, so I think it's time to move on to the next presentation, which is localized RCC and management by Dr. Dunitha Disanayake. Over to you, Dunitha.
Hello, everyone. Hope you can see my slides.
Yes.
Yeah. Actually, I'm going to discuss the management of localized renal cell carcinoma. The most of the contents in these slides were discussed by the previous speakers, as well as the discussion with the Professor Neville, sir. And I will quickly go through the slides without wasting time. So you're familiar with this TNM classification. My first speaker discussed the classification, and here we are discussing about the localized RCC, that is mainly T1 and T2 tumors without nodes and without metastasis. So the most of the T1 tumors are again discussed under the heading of small renal mass discussion. So the available surgical treatments in localized RCCs are either nephron sparing surgery or going with the radical nephrectomy, or there are alternative surgical treatments like surveillance and renal artery embolization and ablation techniques. Those are mainly for the patients who are not fit for surgery, frail patients having a lot of comorbidities, and patients who are not willing for any surgical procedures. So this one also discussed previously. Decision of partial nephrectomy was radical nephrectomy, and there are absolute indications for partial nephrectomy, such as once you do the surgery, if the patient is anatomically and functionally ANF free, then it should be an absolute indication for radical partial nephrectomy, such as in bilateral renal tumors and renal cell carcinoma in solitary kidneys and pre-existing severe renal impairment in contracted kidney. So relative indications are the T1A tumors and T1P and T2 tumors and pre-existing CKD or future risk of CKD. So this slide is also previously we have seen several times. There are anatomic classification systems. The familiar one is renal nephrometric score, and the C index is there. It stands for centrality index. When the C index increases, the tumor is away from the kidney center. And there's arterial-based complexity scores, zonal nephro score, and Padua anatomical classification system. These anatomical classification systems allow objective prediction of the potential morbidity of nephron sparing surgery. So these are common, widely accepted one, nephrometric score. And depending on the score, if it is less than 6, the risk of complication is about 6%. 6 to 9, it's about 11%. And if it is beyond 9, it's about 20%. So these scores are important in patient, discussing with the patient counseling, as well as the treatment planning. So however, when selecting the optimal surgical option for localized renal cancers, these anatomical scores must be considered with the patient factors as well as the surgeon experience. So outcome of each management modalities assessed according to the cancer-specific survival, overall mortality and renal functions, and perioperative outcomes and the quality of life. So for T1 RCC, we have discussed this one earlier. The cancer-specific survival is almost comparable in partial nephrectomy and radical nephrectomy. So there's one randomized control trial, including patients who are having RCC less than 5 centimeters, and shown that comparable cancer-specific survival by doing partial nephrectomy and radical. So what is recommended is partial nephrectomy for T1 RCC. And overall mortality and renal function wise, partial nephrectomy preserves the kidney functions better after surgery. So therefore, low risk of developing cardiovascular disorders later on. So, but in some series of, they have shown that the partial nephrectomy has improved the overall survival patients who have in T1 renal cell cancers. So, but as Dinendra mentioned earlier, this benefit is overall survival benefit is only seen in patients who are younger patients, as well as having without significant comorbidities at the time of surgery. And this Medicare database analysis has shown that surgical outcome of, that means either radical or partial nephrectomy, is equal to the non-surgical management in patients who are having who are above 75 years. And the patient with pre-existing chronic kidney disease, the partial nephrectomy is the treatment of choice. So perioperative outcomes and the quality of life. So in T1 RCCs, intra and perioperative complications wise, there's a one URTC randomized control trial have shown that the partial nephrectomy can be performed safely with a slightly higher complication rate than radical nephrectomy. So partial nephrectomy is the preferred option. And there's only a limited number of studies to assess the quality of life, partial nephrectomy and radical nephrectomy. But available data says the quality of life was ranked higher following partial nephrectomy compared to the radical nephrectomy. So in vivo HOBA and the oncological safety, partial nephrectomy is the chief treatment of choice for T1 RCC. So when compared to the T2 renal cell cancers, the very limited evidence on the optimal surgical management for these tumors, but available data suggests there's lower tumor recurrence and lower cancer-specific mortality seen with partial nephrectomy groups. And when compared the blood loss and the postoperative complications, they are slightly higher for partial nephrectomy in T2 tumors. A multicenter study compared the survival outcome in patients with T2 RCCs treated with partial nephrectomy and radical nephrectomy. So they have found that the partial nephrectomy group had a significantly longer median overall survival and median cancer-specific survival in T2 tumors. So as a summary, partial nephrectomy should be considered in T2 tumors if it is technically feasible, and in patients with solitary kidney, bilateral tumors, or CKD with sufficient parenchymal episode to further postoperative renal function. A bit of about T3 tumors, one meta-analysis shows there's no difference in cancer-specific survival, overall survival, or cancer-specific mortality and recurrence-free survival in partial nephrectomy techniques, and can be used for functional benefit and if technically feasible. So the place for adrenalectomy, and there was a one prospective non-randomized study compared the outcome of radical nephrectomy with or without ipsilateral adrenalectomy. And just because the tumor is in the upper pole, it was not indicative that the adrenal gland is involved. So adrenalectomy is justified using criteria based on the radiographic and operative finding. That means if the adrenal is involved pre-operative imaging, and or if you find that the adrenal gland is involved during intraoperatively, the adrenalectomy is justified, because there's no difference in overall survival at 5 years or 10 years by doing adrenalectomy. So the recommendation is do not perform ipsilateral adrenalectomy. There is no clinical evidence of invasion of the gland. So again, lymph node dissection. There's no place for prophylactic lymph node dissection at all. And lymph node dissection is indicated only if there's CT and MRI detected lymph node masses or palpable lymph nodes during surgery. But that does not give mortality benefit, or it does not reduce the metastasis. That is merely for the control of local control as well as staging. And but evidence says there's some survival benefit in high-grade tumors, such sarcomatoid tumors, very large tumors, by doing lymph node dissection if the nodes are positive. By doing lymph node dissection, they have shown that there's no increasing complications of the surgery. So, and at the same time, we can have a it will give a prognostic as a prognostic indicator, because if there are extracapsular extension, there are more lymph nodes, and it will indicate the prognosis of the patient. So embolization. Before the routine nephrectomy, tumor embolization, as there's no place, and in patients who are unfit for surgery or with non-resectable disease, for the control of symptoms including hematuria, flank pain, there is a place for embolization. So these topics we have Navilis has summarized during the previous discussion. So I will quickly rush through these slides. Radical nephrectomy techniques, open versus laparoscopic or robotic approach. There are no randomized control trial to assess the oncological outcomes of these three techniques. But a retrospective comparative study showed an overall survival benefit in the radical nephrectomy group, as well as in hospital stay, readmission rates, and 90-day mortality rate in these patients. So again, laparoscopic versus robotic approach. there's no difference in the two approach in perioperative outcomes, operative time, or blood loss, and conversion rates and complications. So no difference in local recurrence as well. So then partial nephrectomy techniques, open versus laparoscopic approach, we have discussed this earlier, and there's no difference in progression-free survival or overall survival by doing both the open or laparoscopic approach. Oncological safety also, there's no difference. And this is addressed in several studies with relatively limited follow-up. And the mean estimated blood loss is low with laparoscopic approach, and post-operative mortality and post-operative complications like DVT, pulmonary embolism, those were similar in both approach, with the open or laparoscopy. But the operative times is much longer with laparoscopy, and there's a learning curve is there. And warm ischemia time is shorter with open approach. The result for GFR decline is a bit debatable whether it's open or laparoscopy. Then this one also we have discussed earlier, laparoscopic versus robotic approach, and perioperative outcome wise and oncological outcome wise, there's no significant difference, and there's no significant difference observed regarding complications as well. So laparoscopic transperitoneal versus retroperitoneal approach, again, there's no difference in post-operative complications. This off-clamp versus on-clamp, the one clock study was randomized control trial, was their clock study. Again, the same findings, the comparable safety in off-clamp versus on-clamp partial nephrectomy. So partial nephrectomy technique-wise, depending on the anatomical location of the tumor, it can be polar resection, or it could be just enucleation, it could be a wedge resection, or so this one also previously discussed by the Tesupon. Major complications of partial nephrectomy are the urine leak, reaction hemorrhage, intraoperative hemorrhage, and positive margins. So what is recommended is the one cell layer margin, but during surgery, the assessment of one cell layer is difficult. Therefore, we have at least 1 millimeter margin with the kidney tissue rim is adequate. As I mentioned, mentioned earlier, intraoperative ultrasound scan can assess the deep margins, as well as tumor-based diathermy is also an accepted thing. So rates of enucleation also we have discussed earlier in tumors where we have multiple tumors, such as in multiple endowed, but recurrence rates are higher with high-grade tumors. Otherwise, it's also acceptable. So if you get a positive margin, you can see positive margins in about 2 to 8% in T1 tumors, partial nephrectomy specimens. So, but it does not increase metastasis or decrease the cancer-specific survival. Therefore, even though you get a positive margin, there's no place for radical nephrectomy or going ahead with the resection margins. So what you can do is you can put these patients on close surveillance, and some of them have attempted local ablative methods as well. So then about the intraoperative frozen section, the most trials have showed there's no place for positive surgical margins by doing the intraoperative frozen section. So bit of about the follow-up of the patients. Once you operate on these patients, the following up is also responsible for the urologist. So you have to look for the post-op complications, renal functions, the local recurrence, and recurrence at the contractile kidney, distant metastasis, and the cardiovascular events. So post-op follow-up depends on the risk stratification. The commonly accepted popular one is a Leibovitz prognostic score. It predicts the metastasis. It includes the T stage, tumor size, the lymph node sign node, grading of the tumors, and whether the tumor necrosis and so on not there. So depending on the risk stratification, we categorize them into low risk, intermediate, and high risk. The low risk patients are followed up with CT scans the 6 months, 18, and 30 months, and after 3 years, annually CTs for 2 years. So intermediate and high risk patients need intense follow-up, more frequent assessments at 3, 6, and 12, 18 months assessment, and after 3 years, annually CTs for until 5 years, and after that, 2 yearly has to be done. So this one we have already discussed, place for renal biopsy by the previous 2 speakers. So, and thank you very much, and sorry for repeating the same slides. Okay.
Oh, it's good. It's always good. No. Thank you very much for that very comprehensive talk on that. And I think repetition is not a big problem because that increases the retention power, more you hear about it.
Yeah.
And yeah, any questions from the other panelists, others? Regarding this adrenal involvement, if the adrenal is involvement, how do you state that tumor? Adrenal gland is involved. What is the
So
TNM
it
stage?
becomes T4, sir.
T4. Yeah.
Yeah.
So if it is involved, when you remove the adrenal is not the problem. Whether you should treat it as a local advanced tumor, isn't it?
Yeah. Yes, sir.
So right. And you said partial nephrectomy for T2 and T3 tumors. What is your practical opinion about going for a partial nephrectomy in all T2 and T3 people, if you lesions, if you take?
For the T2 tumors, it mainly depends on the anatomical location of the tumor.
Suppose there is a healthy kidney on the other side. Will you go for a partial nephrectomy or not for T2 and T3?
For T2 tumors, there are evidence that partial nephrectomy would be better.
So what will
but
you do? Your patient.
Yeah.
Your patient, there is 8 centimeter tumor or 9 centimeter tumor. There is one healthy kidney on the other side. No other comorbidities. Would you go for a partial nephrectomy or radical nephrectomy?
So I would go for radical nephrectomy in these patients.
Yeah, good. Why? What is the size of the kidney?
Yeah.
Average size of the kidney is 11 centimeters, 10 to
11
11
centimeters.
centimeters. You take 8 centimeters out of that, how much of kidney are you going to leave? And are you sure that you are going to leave enough draining system, enough blood supply to that kidneys? It's going to be very doubtful, isn't it? So going for T2s, unless there is strong indication, like the other kidney is not there, or other kidney is, say, weak, or overall EGFR is low, then you take the risk. Otherwise, going for T2s and T3s, whatever the evidence is, practical world, unhealthy kidney, go for. T3 means what? T3 and partial nephrectomy.
Yeah.
T3A
means T3A is either involvement of the renal veins or it branches
vein,
and collecting system or renal sinus fat involvement without
so
breaching
if those are there, will you go for a partial nephrectomy?
No, sir. Definitely.
And if it is involving the below diaphragm or above diaphragm IVC, partial nephrectomy is only under very, very under strict criteria. You should go for partial nephrectomy. So practical world, be a little careful. Okay, right. And lymph node dissection, you mentioned something about lymph node dissection. What is the advantage of doing a lymph node dissection, if at all? Recommendation is to do only palpable lymph
nodes.
So what is the advantage of doing that even?
It gives a prognostic information, the local staging and
what do you mean by okay, staging. How does the staging will differ? If there is a lymph node, if they comes as positive, how does the P stage change from negative lymph node to positive lymph nodes? So there is a upstaging. Yes. Yeah. So how does it affect the management?
Subsequent.
Is it going to affect the management or not?
It won't affect the management, sir.
Right. So why bother taking the lymph nodes out there?
Yeah, it is mainly for the local control of the disease.
Yes. So if you don't do the lymph node dissection, what evidence will show that there are no microscopic deposits in all the lymph nodes? And the evidence show that doing the lymph node dissection routinely doesn't make any difference to overall or disease-specific survival.
Yeah.
Okay. Yeah. Only thing is that if the lymph nodes are positive, your surveillance protocol is going to be more strict.
Yes, sir.
Because there's a higher chance of local recurrence. So what do you mean by local recurrence after nephrectomy, radical nephrectomy? Well, how do you define a local recurrence? Types of local recurrence. One is tumor bed recurrence. Other one is vascular recurrence. And last one is lymph node recurrence. Those are three types of local recurrences, out of which what is common and what is rare. If you do a good, if you do a good radical nephrectomy with Gebrras fascia and the perinephric fat, local tumor bed recurrence, pure tumor bed recurrence are very rare. So the recurrence are generally either microscopic deposit or a impalpable lymph node growing again, or a vascular in T3 type of thing, a vascular renal vein recurrence. Okay, so right. Yeah, what is your idea about the completion nephrectomy? Now, suppose you talked about positive renal margins. So when will you consider doing a completion nephrectomies? Go ahead and do a nephrectomy. Is there a place for completion nephrectomy at all?
There are some studies have shown that the recurrence following a partial nephrectomy with negative margins and comparing the negative margins as well as the positive margins, it's about 3% if there's negative margins, and if it is about around 16% if the margins are positive. But that does not increase the reduce the metastasis or survival. So therefore, if we proceed with the completion radical nephrectomy, it will be an unnecessary surgery on the patients.
So your patient will come with a mass after 6 months, which has grown in size after partial nephrectomy, that kidney stump. What will you do exactly?
Then then I will go through the re-imaging and see whether the patient can be offered the second surgery. That of course has to be discussed, and patient need.
You are the only urologist there. Nobody to discuss. Only the oncologist is there for your support, and we may be around to Zoom. But if the size is growing, will you reoperate?
I would consider operating, sir.
Yeah. So what sort of reoperation will you do?
So
will you take the whole kidney out, or any other options you will have?
So if the patient, depending on the tumor, if you can go for a second partial nephrectomy with safe margin without compromising the remaining renal parenchyma, then
is there a place for second partial? Yes, because as for reslicing, you can keep on slicing it until you get a good margin, or you do the radical nephrectomy, completion nephrectomy. And in the first place, if the histology comes as sarcomatoid or any other rare histological type with lower prognosis, then of course you will reconsider doing resection or completion nephrectomy.
Removing the completion.
Yeah. Okay, that's all I have to ask you.
Thank you, sir.
Right.
Are there any other questions?
Donita, now you've done a partial nephrectomy for a T2A and not M0 clear cell RCC. How would you arrange follow-up for this patient?
So that again, following the surgery, we'll see the histology report, and then we've got to go the risk stratification. The commonest accepted one, what we familiar with the Leibovitz score. And depending on that, we categorize the patient into low, intermediate, and high risk. And depending on the risk stratification, I would go for further imaging and follow-ups.
Okay, so what parameters would you consider in Leibovitz, and what imaging? I mean, the answer is all right, but you need to be a bit more specific, please. So what do you consider in giving the Leibovitz score to a patient?
Tumor, mainly it includes the tumor size, whether there's tumor necrosis or not, and grading of the tumor, and T stage, and whether there are nodes.
Yeah. Okay. Right now, if it now say it's Leibovitz 1, how would you follow up?
So it comes under low risk category patients.
That's
So
right. Yeah, good.
then according to the EU guidelines, first CT has to be done at the 6 months post-operatively,
Good.
and then the second one has to be in the 12 and 18 months, and up to 3 years, and then after 3 years, annually CT for until 5 years.
That's a bit too much. So 6 months, 18 months, and 3 years is the recommended interval for CTs. But good that you have an idea about it. One more question now. This positive margins following partial nephrectomy. I think Nevis also tried to touch up this point. What would you do now? You in your mind, you're sure that you cleared the tumor, but the pathology says that there is a positive margin. What would you tell the patient, and how would you what would you do basically?
So now most of our patients, patient will not be aware of the histology report, but the patient is aware of, and the patient I will discuss with the patient that the margins are positive, but just because of the margins are positive, and it won't affect the survival of the patient, or what it is not affecting the metastasis of the tumor. So I will discuss
Now,
with the
the
patient, and I
paper you
will.
quote in your presentation, Dunitha, it's a retrospective analysis. So you cannot randomize patients for a positive margin. You know, how can you randomize patient to have a positive margin? So, I mean, when you quote a paper, you need to be a bit more detailed in what you say. So, I mean, if a well-read, well knowledgeable patient comes, you need to tell them a bit more information about this, you know. Now, at the moment, we don't have solid evidence to say whether this positive margin is going to sort of affect the overall outcome of a patient. But what we do know is evidence coming from retrospective analysis, which is not level 1 evidence, you know. So in that, yes, it's the overall outcome is not different, but the metastatic recurrence and the local recurrence is a bit high, isn't it?
Yes.
So when you quote a paper, it's always good to be a bit more specific. Yeah.
Yes.
Okay.
Thank you. Melissa, do you have anything to add?
Sorry, about this. Yeah, I missed the conversation a little bit. Yeah, this is about the positive margins, isn't it? Yeah.
Yeah, I was telling Dunita that there is no way in the world that you can randomize patients to have a positive
you have
margin.
to, you have to put it in a very sort of a diplomatic way, because they usually take it as a surgical failure. So I have left some tumor inside you is a bit of a shocking thing for the patient. But you must say that you have removed it, whatever you could see. What is visible, you have removed it, but under the microscope, they have shown that there are a few cells around there. But all the evidence, you have to just say that all the evidence shows that you don't need any more operations. That's the biggest scare they have. We have to undergo surgery again. So you just say that what we have to do is, I'll keep a close eye with CT and ultrasound. And if there is any suggestion that it is growing, then we can go ahead and you give a figure. That is a very low chance that this will grow. So you give some very low figure, anyway, it's a low figure, say 1% or less than that, very low chance. So the way you put it to the patient is the most important thing. Don't put it as a
retrospective papers. In that retrospective paper, it's 3 versus 5 metastasis in about 900 cases.
Yeah, exactly. Yes, that is a very rare possibility, isn't it?
Yeah, exactly.
And I think just it is what we all have to learn is how to put it to the patient. Okay, don't just say that we have left some tumor there. So just say that you have macroscopically remove everything, but microscopically it says that there are a few cells hanging around. Just come for regular follow-up. So I think that you can say with clear mind, actually.
Exactly. Yeah. This can happen to anyone.
Exactly. I mean, it is exactly what has happened, because for the naked eye, you have cleared it, but there are a few things left there, isn't it? Right.
Yes.
And also just know that what are the techniques of preventing positive margins. Do you know anything, Sunita? How to reduce the positive margins in a partial nephrectomy?
So intraoperative ultrasound scan guided assessment of the deep margin is one option,
Yes.
sir.
One thing is study the angiography before you go in, and you can do intrahilar clamping. If you know exactly what the artery is supplying the tumor, if you can clamp it, you will get a ischemic line. So if you get a nice ischemic line, you can go through that, and generally you are far away from the tumor once you have clamped the segmental artery. Number 2 is what? Intraoperative ultrasound. Yes, that is laparoscopic and robotic technique. Any other technique, new technique? What is firefly technique? Firefly method. Yeah.
You can inject contrast, and you can assess the the margins.
Yeah. What do you inject?
Sorry, sir, I'm not sure that.
Yeah, read about it. Okay. So it is being used very widely. The last one is the fusion technique, the fusion methods, where MRI images and CT images can be technically fused on the laparoscopic image, robotic image. And then you will know exactly where the tumor is. Okay. So, okay then.
Thanks.
Right.
Okay. If there are no other questions, we can move on to the last presentation. It's about advanced or metastatic renal cancer management by Dr. Shehan Ratnayaka. Over to you, Shehan.
All right, sir. Very good evening to all of you, and I hope you can see my slides.
Yes, we can see.
Right, sir. I'm Shehan, and I'll be talking about advanced and metastatic renal cell cancers. I'm planning to discuss on renal cell cancers with venous tumor thrombi and locally advanced renal cell cancers, which are both resectable and unresectable, and management of lymph nodes in locally advanced disease, neoadjuvant and adjuvant therapy, as well as metastatic renal cell cancers. With regards to renal cell cancers with venous tumor thrombus, it is an adverse prognostic factor, especially the level of the thrombus if it is higher, as well as microscopic invasion of the IVC wall are strong negative predictors of survival. All in all, about 4 to 10% of patients with renal cell cancers have a venous tumor thrombus, and majority of these patients surprisingly do not have systemic metastasis, even though there's a part of tumor inside a vessel. So a radical nephrectomy and an IVC thrombectomy will provide an overall survival of about 40% at 5 years in these patients. With regards to the staging of the IVC thrombus, both the TNM staging as well as Mayo classification are used. And the TNM staging acknowledges the IVC wall microscopic invasion as well, a direct invasion as well. At the same time, the Mayo classification is a more surgically oriented staging system, which stages the thrombus into 5 categories, starting from 0, where the tumor is limited to the renal vein, and extending up until the supradiaphragmatic IVC and the atrium. So with regards to the imaging, appropriately performed CT will provide a lot of information about this tumor thrombus, and the differentiation between the bland thrombus and the tumor thrombus can be done with the contrast enhancement, which is similar to the tumor, as well as the direction of the thrombus. And if you are uncertain, MRI will provide more information. Regarding the management of venous tumor thrombus, the current EAU guideline recommends that in a patient with non-metastatic disease, that the tumor thrombus is removed with a tumor thrombectomy and to do a radical nephrectomy for these patients. And this is irrespective of the extent of the tumor thrombus. The role of neoadjuvant therapy, there's no consensus regarding that, and apart from a trial setting, it is not recommended to be given in the routine clinical practice. Preoperative renal artery embolization it does reduce the level of the thrombus, but it has not translated into reduction in blood loss or complications. So it is again not recommended in routine practice. Regarding the surgical approach, it is tailored to the level of the thrombus, and it can range from just a side clamp to the IVC and removal of the venous tumor thrombus to a complete mobilization and venous isolation of the liver and cardiopulmonary bypass. If there's invasion of the IVC wall, it needs resection of the IVC wall to achieve a negative resection margin, which will reduce the recurrences in the future. And by doing this, if there's a reduction, more than 50% reduction of the luminal area in the IVC, a reconstruction should be done to prevent the venous congestion downstream. So patch grafting or reconstructive techniques should be used. But if it is completely occluded IVC, there will be a lot of collaterals, and these patients, you can avoid a reconstruction of the IVC. With regards to the removal of the bland thrombus, if you can remove it without a lot of complications, it is acceptable to do so. But if you're leaving it behind, can consider an IVC filter or ligation of the IVC in the case of a completely occluded IVC. The second part of my presentation is on locally advanced renal cell cancer, which are the T4 tumors. When it is resectable disease, even if it is involving adjoining organs, what is recommended is to do a on-block resection of the adjacent organs, which might be the bowel or the spleen, and it will give you a curative resection. But compared to organ-confined disease, even after a negative margin and curative resection, the prognosis is poor in this patient cohort compared to the localized tumors. If it is locally advanced unresectable disease, the primary mode of treatment is systemic, but the decision should be taken in a multidisciplinary stage. And if we are offering any treatment, most of the time it is for local treatment for symptomatic control like embolization. Regarding the role of lymph node dissection in locally advanced renal cell cancers, the chance of having a positive lymph node in a clinically negative lymph node patient is about 25%. For pathologically, they will have 25% of the patients will have positive lymph nodes. And if it is clinically node positive patients, there will be a chance of about 54% of patients can have positive lymph nodes. And this subset of patients with positive lymph nodes are at a higher risk of recurrences. So the current evidence regarding lymphadenectomy, the earlier studies, the URTC 30881 study has shown that there is no benefit in patients by doing a lymph node dissection with regards to overall survival. But few criticisms about this study is that most of the patients have been having organ-confined tumors, and the lymph node positivity has only been 4% in that cohort of patients. But later on, the systematic reviews and meta-analysis has been performed, and they have again given contradicting results. And a study which has been done in 2019 has shown that in the locally advanced tumors, there's some benefit of doing a lymph node dissection. But overall, since the evidence is not very clear, current recommendation is to remove the visible as well as palpable lymph nodes at surgery, but not to do a template lymph node dissection, because it will provide more accurate staging and prognostic information, which will help us to guide the follow-up as well as to consider adjuvant therapy in these patients. But again, no cancer control benefit is conclusively demonstrated. Regarding the neoadjuvant therapy in advanced renal cell cancers, again, it is not recommended by the 2024 guideline because it gives a lot of the tyrosine kinase inhibitors and immune checkpoint inhibitors are associated with a lot of side effects, but it hasn't given any consistent result of benefit. Regarding the adjuvant therapy, following a curative resection, about 20 to 30% of patients will go on to develop metastatic disease, especially the high-risk categories of in Lebovic score. So these patients, it sounds rational to give adjuvant therapy, but the guidelines does not recommend giving tyrosine kinase inhibitors as adjuvant therapy because of the unfavorable side effect profile without any obvious survival advantage. And two of the main studies, the STRUCK and the SURE trials, have shown that adjuvant sunitinib therapy compared to placebo has not given any significant survival benefit. At the same time, the SURE trial has looked at the timing of adjuvant therapy, whether it's again, Assure trial, they have not seen a clear benefit. But the current guideline gives a weak recommendation for adjuvant therapy with pembrolizumab, which is an immune checkpoint inhibitor. According to the Keynote 564 trial, in the high-risk category patients in these, there has been a disease-free survival benefit, but again, not an overall survival benefit. So if you're considering, it should be given within 12 to 16 weeks of the radical nephrectomy. The last part of my presentation is on metastatic renal cancers. So at presentation, about 25% of patients have metastatic disease. This percentage might be decreasing because of the higher detection of small renal masses, which are detected incidentally. But further 30 to 40% of patients after curative resection will still go on to develop metastasis. And once they do develop metastasis, they have a very short 5-year survival of 15%. The treatment-wise, it is mainly systemic treatment that we are offering to these patients. The prognostic models for metastatic renal cancers, there are two, the MSKCC system and the IMDC system. They are both looking at the prognosis of patients and considering most of the variables. They are all they are common to both prognostic models, and ultimately it will categorize patients into favorable, intermediate, and poor risk categories. And the further treatment is dependent on these prognostic categories. So I would talk about metastatic renal cancer, the local therapy as well as systemic therapy. Local therapy to the primary tumor. Regarding cytoreductive nephrectomy, it has been a topic of debate for a long time. So earlier in the interferon era, there has been a survival benefit which has been demonstrated, but later on, when it comes to tyrosine kinase inhibitors, the Carmina trial has not shown any overall low progression-free survival in these patients. And they have included intermediate and poor risk patients. So because of that, that is a criticism regarding this study, because most of the patients have had poor risk category. The EORTC third-time trial has looked at the timing of the systemic therapy with regards to cytoreductive nephrectomy. And in fact, there's been no overall survival benefit with regards to giving cytoreductive nephrectomy. In fact, there has been a trend towards better overall survival with deferred cytoreductive nephrectomy than immediate cytoreductive nephrectomy. But when it comes to immune checkpoint inhibitors, studies are underway, and there are evidence both to and against cytoreductive nephrectomy. So the current guideline recommendation is that patients who have limited metastasis, single or oligometastasis with a good performance status and a resectable primary, we can offer immediate cytoreductive nephrectomy along with addressing the metastatic deposits as well. And the treatment intent can still be curative, which will provide a survival benefit. But all the other patients should receive the systemic therapy as their priority treatment. And after the systemic therapy, there might be a place of offering cytoreductive nephrectomy to the patients who respond well, that demonstrate a less aggressive disease. Local therapy to the primary tumor, in a patient who has metastatic disease, it's limited to symptom control, and commonly we offer embolization to control hematuria and flank pain. And regarding the metastasis, again, local therapy is offered for symptomatic control, and there are an array of treatment modalities, including ablation therapy, radiotherapy, and embolization. The systemic therapy for metastatic renal cell cancer, currently the recommended first-line treatment is combination therapy of immune checkpoint inhibitors and tyrosine kinase inhibitors. This applies to all categories of IMDC risk groups. But single therapy or monotherapy of sunitinib and other tyrosine kinase inhibitors can be considered in patients who are not tolerating the immune checkpoint inhibitors, or patients who don't have access to immune checkpoint inhibitors. But at the same time, it can be considered in patients in the favorable risk category of IMDC prognostic scale. What is recommended is sequential therapy. I will show in the next slide the recommendations. But the systemic therapy after a patient who has had metastatictomy and primary tumor removal, who end up with no evidence of metastatic deposit afterwards, immediate tyrosine kinase inhibitor therapy as adjuvant therapy is not recommended. So this is the current combination therapies according to the IMDC risk category given as a first line therapy, and it combines a tyrosine kinase inhibitor as well as a immune checkpoint inhibitor. And these are the subsequent line of treatment that can be offered depending on their first line treatment. There are multiple trials which has looked at the systemic therapy with immune checkpoint inhibitors and their survival benefit. And most of them have compared with sunitinib, which is a tyrosine kinase inhibitor. And it includes Keynote 426 and Checkmate trials. And most of them has demonstrated a progression-free survival, but overall survival benefit is not very marginal. This is a diagram of how the the immune checkpoint inhibitors act. And that brings me to the end of the presentation. And thank you all for patiently listening to me.
Thank you, Sean. Yeah, it's a very nice roundup of metastatic renal cell cancer. I think it has moved from us to the oncologist. I think if you have realized it, trying to remember the names of the ICIs, I think itself is like trying to remember the telephone directory. So I think you've covered most of it. So any questions from the others? Basically, what we have to know is the place of nephrectomy in these patients. So if you can summarize, when will you do nephrectomy in a metastatic RCC? I mean,
yes, sir.
you gave all the details, but
yes, I would
suppose
consider...
there is a patient, let me say, there is a one deposit in the lung, and there is this, say, 9 centimeter or 8 centimeter mass in the kidney. So how do you proceed?
So I would look at the patient's performance status as well. If it is a relatively young patient who has a good life expectancy, I would consider radical nephrectomy for the kidney as well as probably a
Are those the only
resection,
two factors you will consider? What is Karnowski? Would you performance status, will you assess in more detail, or?
Yes, sir, the comorbidities of the patient and how they are, whether they are independent in their activities or daily living, and their age and their life expectancy.
Right. Okay. And then what
so
investigations will you do? Because you have seen a chest X-ray, there is a opacity.
Yes, sir. So I want to exclude that there aren't any other occult metastases, sir. So in that case, if I have access to a PET CT, I would consider that. But at least I would screen the lung with a contrast-enhanced CT before proceeding with metastatectomy.
Yeah. And what is the place of bone scans and brain MRIs?
If they're symptomatic, I would consider those, sir, but I would not do it in a routine basis.
Okay, so the CT also shows there is only one single metastasis and this tube. So can you summarize your management? With all this big lot of knowledge,
yes,
put it into practice.
Yes, sir. I would offer this patient a radical nephrectomy. At the same time, I would discuss this patient at a multidisciplinary team, sir, to which sequence I would take, whether to do the radical nephrectomy first for the lung first. But after that, radical nephrectomy.
Oncologists suggest that we'll give a course of pasopanic, axitinib, which has just come to his hands. And he said that, shall we try this to see whether this tumor will shrink so that it's easy for you to cut, and to see whether the metastasis will disappear. This single metastasis, in which you don't have to do a pulmonary wedge dissection. So would you agree, or how do you tackle that, man?
I would consider surgery first, sir, because we can't predict the response of the patient.
So what evidence will you throw at him against doing a neoadjuvant AKIO ICI? Because I went through everything. So how do you put it into practice? Would you say there is evidence to show what he says is true? He said that, well, let us try it for about 6 weeks and see how will you argue against it?
No, so the current evidence say
Yeah.
that it, like in a patient who has resectable disease at presentation, we should proceed with resection rather than the systemic therapy.
Yeah.
Sir.
What studies will you attack him with?
I'm not really sure about
Say
the
that.
name of
But you just mentioned. What is Assure and Extract?
yes, sir. Assure
Source,
trial.
Protect,
Yes.
Atlas, they are all studies you can attack him with. So what does those say?
Yes, sir. So the extract trial has looked at sunitinib versus placebo, sir. So in that, it's not shown any significant survival benefit. At the same time, there's a lot
Assure
of
is sunitinib, Extract is sorafenib. Source studies. The source study is also sorafenib, and Protect is pazopanib, and Atlas is axitinib. None of them have shown there is a survival benefit or any kind of benefit. This is specific survival. If you give it in a adjuvant or neoadjuvant, so neoadjuvant treatment is against it. So you will, okay, then you will go for nephrectomy, you said. Okay.
Yes,
and what about the metastases?
If possible, at the same setting, or maybe once the patient recovers from the nephrectomy, I would offer like a wedge resection of the lung nodules. Afterwards, afterwards, I would consider adjuvant therapy, but again, it is recommended not to give adjuvant therapy immediately in patients who has no evidence of disease after metastatectomy. And we can keep them on close follow-up to see whether the disease progresses, and at that point, we can consider adjuvant therapy.
Okay. So what does the Carmina trial say? It's very commonly asked trial. So
Yes.
What is the outcome and what are the criticisms of Carmina?
Yes, sir.
What is Carmina trial?
That looks at cytoreductive nephrectomy in patients who are given sunitinib versus sunitinib alone, sir.
Alone, yes.
Yes, so the criticisms are
Outcome?
Yes, outcome. There's no overall disease specific survival by offering cytoreductive nephrectomy. But the criticisms are they have included a lot of intermediate and poor risk category patients, so they anyway have short survival, sir. So because they
you mean to say that which category was included more ill patients? Surgery alone or surgery with sunitinib?
I'm not sure, sir.
The main criticism is that 7% of them have not undergone nephrectomy, cytoreductive nephrectomy, because we are supposed to do cytoreductive nephrectomy with pazopanib. So 7% of that trial, they have not undergone nephrectomy. So they fall into the other arm. And then 18% of them, they have not taken AKIs because of the toxicity. So those are Carmina trial is criticized, and its validity is also questionable now. Why? Because now the first line treatment from 2018 is what? For
checkpoint inhibitors.
CIC checkpoint inhibitors. So because of that, the Carmina trial's validity is going out now.
Yes.
Because it is only
just to add to that point, sir. Just to add to that point, as you very correctly said, I mean, if you want to remember two trials in relation to renal cancer, I would say it's Carmina and possibly Rampart, because Rampart is recruiting these days for adjuvant treatment. So, I mean, as you very correctly said, I mean, Carmina is very widely criticized for a lot of problems. You know, first of all, I mean, it is a non-inferiority study. So non-inferiority means that we always, the standard of care is cytoreductive nephrectomy, and we are trying to say whether it is comparable or not. It doesn't say that it is better or anything more, you know. And the other thing is it's very, it's very easy to sort of establish non-inferiorities, say, statistically, you know. I mean, I mean, rather than doing a RCT or anything, because it's this design is at the first place is a problem. And as you said, I mean, they've only compared the IMD. Oh, the other problem is it's MSKCC, it's not even IMDC. So at the time of recruiting patients, it was MSKCC. So IMDC was not even in place to categorize patient accurately. So now currently it is IMDC. So there's not much of a difference between MSKCC and IMDC, but now we talk in terms of IMDC. The other problem, as you very correctly said, now we don't even talk about sunitinib. We talk about nivolumab is the first line treatment now. So there's lots of problems about Carmina. So if you remember at least one study regarding renal cancer, it has to be Carmina. And if you want to remember one more, I would say it's Rampart, because it's at the moment it's one of the very widely argued area in renal cancer management.
Thank you, Supun. I think it's very elaborative, and yeah, I think that's it. That's all I have to ask about.
Anyone else having other questions?
Shahan, I'm Indrajit here. May I ask a bit of a practical question in our setup, actually, having lack of multidisciplinary meetings, particularly. So what kind of patients will you refer to oncologists after having radical nephrectomy? So in your practice, I hope Neville sir can elaborate on this, considering the practicality.
Yes, thanks, Indrajit. The thing is that actually after curative resection and preoperatively well-localized cancer and non-metastatic cancer, I think the urologist should do the follow-up. And I think once we have sent the local practices, once we have sent these patients to oncologists, they have to, most of them think that they have to offer something. So, fortunately and unfortunately, some of these pasopanib, all these TKIs and some of the ICIs are also available now. So they are very expensive, but they are available. So if when those are available, they tend to start some of these patients on those things without, with all due respect, without any strong evidence. So I think in the lack of without having my MDT meetings and having face-to-face. That's why I put one of these presenters, I put the situation of confronting with the oncologist. So that is exactly what is going to happen if we had MDT meetings. But if you don't have that, I think I will be asking for oncological help only when it comes to metastatic cancer. And there is proven metastasis. I think once the follow-up is done according to the guidelines, and if at any moment, if we feel that there is a metastasis, then of course I'll always involve the oncologist. And from the beginning, if there is any metastatic situation, then I will always call a oncologist to join hand. But many patients will ask to go to oncologist. Should I take a opinion from oncologist? But I think what I would advise is ask them. If you are referring it to, refer to an oncologist who is close to you, with whom you can discuss. Just don't ask him to just go to any oncologist. So it is always nice to have one oncologist in touch with you. Just, you refer patients, you get a feedback. So then you speak the same language, and then you can always ask that oncologist what are you planning to do? Because otherwise they will get lost in this jungle of Maragama. With so many oncologists, with so many ideas, and then the best treatment will not be given. So I think I would involve a known, personally known oncologist, because we don't have uro-oncologists, in a metastatic situation. I hope that I have answered the question. Is that what you expect?
Yeah, of course, sir. It's a great advice. Thanks so much.
Any more questions? Okay, I think, I would like to thank Professor Neville sir and Dr. Supun as our expert panel for today. And I think we had a fruitful discussion regarding renal cancer management. and hope to see you all for the next Uromet. Thank you and good evening, everyone.
Thank you very much, Gihan, and all the panelists. And thank you, Supun. Nice to see you. and I think your presentations were really good. And only thing I think in future, I think I would suggest the panelists and the expert panels to direct more practically oriented questions, which will be asked at Vivas, at the exit Vivas. So I think at the end of a short presentation, we should be more clinically oriented, and it should be a sort of a kind of a case-based discussion, a case taken and then discussed with the evidence available and the details, because some of these things I think are very theoretical. They are good for your MCQs, but I think Uromet, I think, should get evolved a little bit. I will suggest that to the organizers.
Thank you, sir.
And the panelists should get prepared with some clinical questions for the presenters, so that they will be retrospectively thinking of what they have talked about. Okay, then.
Thank you, sir.
Thank you. Thank you then. Good night, everybody.
Right. Thank you.
Thanks. Thanks. See you.
Thank you, sir.
Thank you.
Thank you.